So I'll start off by introducing myself. My name is Mimi Salamon Mahadera. Most people call me Mimi. All my patients call me Mimi. And I'm a family nurse practitioner of about 24 years now, and primarily in primary care, women's health, and integrative mental health with primary care. I am also the Chief Clinical Officer for One Love Center for Health, and I'm here with Jerusalem Makonnen.
Hi, welcome again in Damalachu. I'm in Jerusalem Makonnen, Jerusalem, in the US. And I'm also a family nurse practitioner. It's really wonderful to have a colleague that's also from our land that we work together. It's been wonderful. I've been a nurse practitioner now for this will be my 30th year, which is crazy. I work in primary care, I with a focus on women's health specifically, and most recently became a menopause certified provider with Menopause Society certified practitioner. And it's been wonderful delving into that journey as well. Welcome.
So, our agenda today, this is going to be a conversation between Jerusalem and I, and we'll address questions from the audience at the end of this live discussion. So please send us your questions as they come up using the chat box. You'll also be able to unmute yourself and to ask questions as well. And the question session, when you unmute, can be interpreted in Tigrinya, and you may also ask in Amharic, as I mentioned earlier. Today, we'll be diving into a discussion about hormones. Primarily, want to focus around perimenopause, menopause, postmenopause, and the role of hormone therapy. But let's start simple. As you can see here, there's a graphic on your screen. Um, and let me move this around so I can see the graphic as well. Um, so I just want to remind everybody here that people who are born female are all born with all the eggs they will ever have. So it starts at birth for us, even before birth. But with these eggs that we have, there will be different phases in our lives. And as we transition from childhood to womanhood and we enter into puberty, at now that age is around 10 years old, our hormones start to move in sync and they repeat every month in a cycle. And this will produce your menstrual cycle. And it's driven by estrogen and progesterone, which thicken and shed the uterine lining alongside follicular stimulating hormone, which is known as FSH, and luteinizing hormone, which is known as LH. And these regulate egg maturation and release. And these four hormones rise and fall in a precise feedback loop to prepare the body for potential pregnancy every month. And you can see this in this graph, in the first graph, how you see that there is some sequence to it, and that just repeats every month, and that produces our warababa at the end of each cycle or the beginning of each cycle. So it takes a few months after puberty for our cycles to become regular. But once our cycle starts, we're able to conceive during a specific window of time each month, and that's ovulation. During this phase in life, we can conceive naturally. It can be harder to get pregnant after the age of 40 years old, and women who want to delay pregnancy should consider freezing their eggs before the age of 35. So I really wanted to put this piece in because there's a few things that are happening in our society now. I think a lot of women from all different cultural backgrounds are choosing to delay pregnancy. A lot of times they're trying to build a career, or sometimes it's migration in many of our cases. So whatever the reason may be, that there is this misconception that we can, have children well into our 40s. And for some people that may be, but for some people that won't be the case. And so to have a realistic view when you are planning your future family. So once we sort of move out of this phase of being childbearing age, we go into a phase of can be both. You can still be childbearing, but your hormones are starting to act a little bit differently. Your body's starting to do other things, and we call this perimenopause. And we actually have a guest with us today. Her name is Kiko Asmerom, and she's here to tell us about her journey. And I think that we will probably all learn something from this. Hi, Kiko, welcome.
Boy, do I wish I had that slide earlier in life. I understood that the role of progesterone and estrogen and how that played in our cycle. We only know that we have it and we bleed every month. And as long as that's happening, that we're good. And even though in my story, like I knew that intellectually, I knew that perimenopause can start as early as in your 30s, but the only sign of that to me was that your period stops or your period is irregular, and that wasn't the case for me. I'm in perimenopause, and I am regular as I've been in the past. So my experience was a little difficult to diagnose, and I didn't crack the code until maybe a year ago. That's all the symptoms that I experienced in my late 30s and early 40s through my 40s was because of perimenopause, and nobody can answer it for me. So like I think at 42, I experienced frozen shoulder, and it happened while I was working out. Like I literally was doing shoulder raises and I couldn't lift my shoulder. And I was like, what's happening? And I kept pushing because I couldn't understand that. It was 5 pounds. I can do 12. Like this didn't make sense. But I did go to my doctor, and she was like, oh, let me send you to someone who can look at it. And it was like impingement. We don't know what's causing it. It happens for women who are of color in their 40s. There's no explanation. And I am type 2, although that's controlled. And they were like, but yours is controlled. So it doesn't make sense. Let's do MRI, and went to all of that. But no, like it never occurred to me these were symptoms of my perimenopause. And nobody, not my OBGYN and not my I forget what they're called, the shoulder doctors, or my regular doctor. Nobody explained that to me. And then life that went along. And then 2 years later, 45 or so, I couldn't sleep. And so I was like, well, I'm not much of a good sleeper. I've never have been. But this was different. Like I was laying awake until 4 a.m., like not shutting my eyes at all, just wide awake. And I was like, this is crazy. And so I was like, maybe I need a sleep test here. And I did have a history of sleep apnea in the past. So I called my endocrinologist and I was like, hey, let's do a test here. But I did say to her, could this be my hormones? And she's like, no, you have history of sleep apnea. Let's do that. And so she sent me to a sleep doctor. We tried medication there. That wasn't working. And finally, reluctantly, she tested my hormones. And she was like, well, okay, I think you're 2 years away from menopause, but I can prescribe you HRA if you need it. But never took the time to explain to me what was happening, why, the sleep was causing all of that. And although I picked up the medication from the pharmacy, I was like, something is missing. And I didn't feel comfortable taking it. So it was sitting in my cupboard for like a year and I had to throw it out. And luckily, I was really lucky. I met someone, a physician, during a retreat, and we became friends. And I'm in the Bay Area in California, and she lives in Maryland. But I was just feeling, and I just didn't trust my doctors. I was like, they're not giving me the explanation I need. And I started doing my own research, and all the doctors I wanted to work with were outside of the state, and I'm like, how can I trust them either? So, and I knew she was a physician, but it didn't land to me in my head that she was an OBGYN. So I went to her website. I was like, oh, she's an OBGYN and she's a functional medicine at that. This is great. So I didn't tell her, but I made the appointment with her clinic, and the nurses were amazing, and they had me do a bunch of labs and tested for everything that even my own doctors were not looking at. And so when the results came and I finally met with her, like she took an hour and a half to explain to me each of the test results and why and how that was impacting. And she was like, your estrogen is great. It's your progesterone that's causing all this havoc that you're having. It's impacting your sleep, it's impacting your nervous system. And I'm like, why isn't anybody explaining that to me? Why isn't put people like it just didn't make sense, you know? So I was really grateful for that. And she was really honest with me, and I was like, well, but estrogen is going to come into play in a while. And she was like, well, let's cross that bridge. She was like, I'm not quite as happy with it, but let's cross that bridge when we get there. And I make that point to say that 6 months later, my hips started hurting. And then I was like, my doctor was like, okay,
Oh my
well,
God.
let's get an X-ray. And so I have mild arthritis in my hips now. And so she was like, well, I want to know if you have osteopenia, the loss of bone density. So went for that, and she was like, we might have to now have the conversation of estrogen. And I was like, well, I thought you weren't keen on that. And she was like, well, this now becomes a question of the two evils. Like, is it better to take this, even if it's not the best? And like, I'm not 100% satisfied with it to save your bones, which are going to be important. So I appreciated her honesty and giving me those and understanding the what do you call it? What am I trying to say here?
The risk versus benefits.
Thank you. Yes. Um, yeah, so I feel like with her, I have been able to navigate this a little bit more. And then recently, like I got another diagnostic, which kind of made me feel like I couldn't take hormone replacement therapy. And so I called her again. She was like, this is all because you're estrogen dominant. I never understood that I was estrogen dominant, but my whole life there were signs of that. And nobody was like, I really had awful cramps. It was just like, and none of my doctors, like the specialists I've seen in the past have said, we need to correct this. It was always here, take birth controls to manage the pain and all of that. And that just masks the symptoms that we're having there. And so then through that conversation, she put me on over-the-counter herbal medicines that help detoxify the liver. Because right now, I'm estrogen dominant, which is causing other issues, and progesterone is low. So how do we manage that? And I'm figuring this out. It's like we need to detoxify the liver. Your gut is impacted with lack of estrogen and all of that as well. My sugar is a little bit higher now and harder to manage. So it's like constant learning. And it's a little bit frustrating also that, my local doctor doesn't understand all of that and doesn't have the time to kind of walk me through it. And it's on me to kind of figure that out. So I'm working with various people to kind of the piece the little things and see what makes sense to me and what's good for me and what feels right for me. And that's the thing, you have to trust yourself and your intuition on what's good for you. So now I'm just focused on herbal detoxing the liver, supporting the kidneys, making sure my gut biome is on point and really eating right. And that's why I'm excited to be here, to just have two nurses who, are sisters to provide that. So thank you for this.
Thank you so much for being here. Oh my goodness. And thank you so much for just sharing that story and being very honest with us. I think that all of us have a lot to learn. The biggest thing that I take away is that that you listened to your gut, that you advocated for yourself, and you didn't stop.
Yeah.
Despite all of these experts in your life not
Yeah.
listening to you. So I really think that's what we learn, and that's what we try to do every day in our careers is listen to that person sitting in front of you. If I do anything else on my day-to-day when I see patients, just making sure I listen to their story and listen to it before I do anything else. That's been my goal, and we learn too. It's also a journey. This is not content that I was necessarily taught specifically when I was in nursing school, when I was studying to be a nurse practitioner. These things evolve, the research has evolved, and we'll talk more about that. But really, I admire you. Thank you for that. And we'll get into it. And really a good jump off point for this because perimenopause is that. Perimenopause is that period of time between what the time that Mimi was talking about, where when our cycles are seemingly very regular, and then all of a sudden the chaos starts, right? If you look at that graph in the center, that's basically what's happening and leading up to menopause, which would be around like 51, 52 on average. So anywhere 2 to 10 years before that time, your cycle starts to look like that, where it's not that perfect regular situation, where estrogen can, it's not taking a dive like we think. It can be high and low. So that's why when you have high estrogen, you have these specific symptoms like migraine headache, joint pain. You can have breast tenderness. You're like, why all of a sudden, why am I having breast tenderness before my period? So all of these symptoms and that mood swings, all of that happens because of that volatility. And then sometimes we call it a second puberty because of this. It's a little bit like a roller coaster. Um, but one thing to understand too is that not everybody goes through this in the same way. We're all individuals, and all of us have a different journey because of many different things: our environment, our lifestyle, our own hormones, and how they shift depending on what's going on. Other things that might be happening, like our thyroid, like diabetes, other metabolic situations. But this is very real. It happens. One of the first things my patients tell me is, and one of the first things we see is that shift in the menstrual cycle. So your cycle, which has been regular, might start to be maybe a few days late, maybe 7 to 10 days. You might see that there's longer gaps. Maybe you get a period maybe once every 2 months. Maybe you get a longer period. And all of this is quote unquote normal in this wedge of time. Um, what can I do about it, right? Like, what are some things that we can do about it? And in this time, I really tell people really like some anticipatory guidance around lifestyle. Kiko explained it really well. That sleep disturbance is very real. For some people who have never experienced insomnia, all of a sudden, out of the blue, I can't sleep. It's insane. And sleep is one of those things, like I said, it's medicine. So getting into a regular cycle, going to bed at the same time every day and trying to wake up at the same time throughout the week, and don't waver on the weekends. Try to keep that regular. Getting into regular work around your exercise, around meditation, around going outside. These are things that are going to help our cortisol to come down, right? So this is a hormone, another hormone that plays a piece when we have stress. Another thing that people talk about is this weight gain. They're like, I work out every day. I eat everything perfectly. Why am I gaining this weight? Especially that weight around the middle. That's another thing that starts to accumulate around this time. And that can be very frustrating for a lot of people, especially since you're making so much of an effort. Um, We'll talk a little bit more about this a little bit later in more detail, but some of the treatments can be using combined hormonal pills. It can be menopause hormone therapy. We try to call it menopause hormone therapy because we're not really replacing your hormones at this point. We're giving you hormones to help you in this transition time. Replacement would imply that you don't have any hormones left, right? I want to point this out for folks that are under 40 and say stop their period completely for 2 to 3 months. That's unusual. There are people like that that have primary ovarian insufficiency that we might need to replace their hormones. We call that hormone replacement therapy. And that's unusual. If something like that's happening, that's a red flag. Please do check in with your provider. And anyway, we'll talk more about the specific treatments and alternative treatments and treatments like Kiko was mentioning, herbal treatments as well that have been studied for some folks and do work for some folks. And I also want to say, really important not to feel helpless. The bottom line is recognize that that's happening to you, because especially if it's out of the ordinary and it's starting to affect your quality of life, you don't have to put up with it. And many of my patients come in telling me they don't feel like themselves. If you have that thought, please do check in with your providers.
Yeah. Thank you, Jerusalem, and thank you, Kiko. I think your story is meaningful because so many people experience this, and they don't know, they can't put their finger on it because it's not one thing that's happening. It's many different things that are happening, and you don't connect the dots because it's your shoulder, then it's your sleep, then it's your, um, fatigue. And another thing that Jerusalem was talking about when the chaos happens with the hormones. And the periods may come regularly, but the timing of the period initially could come closer and closer together. So something that I would see often for women in their 40s is they would have excessive bleeding, meaning that they would have more than one period in a month, like every 3 weeks or so, and they start feeling really fatigued. And unfortunately, or fortunately, I'm not really quite sure yet, there's a lot of information about perimenopause and menopause online now. And um, there's a lot of information that sometimes, if you haven't really dug all the way down to what they mean, can be misinterpreted. So fatigue, yes, I mean, I am a perimenopausal woman with 2 kids and several jobs, and I'm fatigued. But if you're saying, oh, it's just my hormones, oh, it's just hormones. But what's happening often is women in this age group may be excessively bleeding and now they're anemic. And so, yes, there is a hormonal component to it, but the real issue is that they've had a lot of blood loss. So heavy periods, longer periods, closer together, and then they start to space out later, and you may get other things. Another symptom I hear a lot of during perimenopause is the night sweats that would happen. And as Kiko mentioned and Ursula mentioned, really lifestyle can change a lot of things. And if I bring the conversation back to our community and our culture, um, I don't know how many of you have ever asked your mom about their menopause experience and what kind of answer you may have gotten, but often I hear like, I don't know, it didn't really happen to me, or I didn't feel that, or and I think it's because the perception, also the time, it was a different time, and people didn't really speak about this, and culturally, it's not always something that we necessarily would talk about, but um, the perception and the information that they had was different. So I think that people experience things and how they perceive their experience is also telling of how they will address it. And so there is a problem, or could be a problem, of over treating or over medicating. And first thing I always start to share with women when I see them for issues around hormones is that perimenopause is normal. This is a normal thing. We are not sick. It's like pregnancy. There are certain things that happen during pregnancy. You're nauseous, you're tired, your hips hurt, but that's normal. That's supposed to happen in pregnancy. So just bringing that context back as maybe our mothers, like this is a normal part of my cycling through life in different phases, and this is a phase that's happening. So just remember that you don't have to treat it, but you could make some adjustments to your lifestyle that could help it. And then there are other things that if the symptoms are impacting you enough that you do need some treatment and that will help you and help your quality of life, then I think that it is something that we can also consider. But let's move into menopause itself. So menopause is actually just one moment in time. And this is the 12th month anniversary of your final menstrual period. So once you've had your last period and you marked it on your calendar and you see that you have reached one complete calendar year, 12 months of no period, 13 months in our case of no period, then you have achieved menopause. And this is an achievement, right? This is now you're graduating to your next phase in life. Usually happens around age 52 in the US. Sometimes it depends by country. The age might vary a little bit. I think that might have a lot to do with diet and how people live their lifestyles. But here in the US, 52, I think, is the average age of menopause. And once you've reached that 12 calendar month mark, then you are considered postmenopausal. And what that means is that hormonally, the ovaries have essentially stopped producing estrogen and progesterone. Your body still does have a little bit of those hormones, but not anywhere close to what we were working with prior to this time. Um, and this is when women will experience really the peak of their symptoms, particularly hot flashes, vaginal dryness, urinary issues, pelvic floor issues, and changes in their metabolism, a lot of like belly fat that will start to happen despite exercise, despite, eating right. So these are symptoms that also may begin in perimenopause, but you might see um, a more drastic expression of them during this postmenopause period. But eventually, I'd say for many women, about past 5 years or so, it could, though, for other women continue forever, forever, but maybe not with the same intensity. But for most women, for about 5 years after. And then things will start to settle. Whatever symptoms you're having will start to minimize. And then we want to focus then on reducing the risks of chronic conditions that could be impacted by not having these hormones circulating the way they used to. So heart disease, osteoporosis, Kiko mentioned, and that's when your bones start to become more porous without estrogen. Um, and also cognitive decline and pelvic floor issues. Those are all things that we may experience or have a higher risk for in the postmenopause time. So I want to remind people that estrogen, naturally is cardioprotective. It also supports bone density and plays a role in our pelvic floor and our pelvic health. So, exercise is key during this time in your life for your heart, for your bones, and for your pelvic floor. You don't want gravity and time to just let everything go south. And then also plays a role in your brain health. And so estrogen sometimes is recommended for women who are experiencing not only symptoms, but issues with their heart health, their bone density, or cognitive health and their pelvic floor. So there is a time and a situation where hormone therapy is recommended, and I think Jerusalem will be able to talk to us about that because there's also a window during that time when hormone therapy is most effective to be preventive for these risks. Jerusalem.
Thank you, Mimi.
Yeah.
Yeah. So we'll move on to talk about menopause hormone therapy. And just backing up, Mimi was talking about estrogen. And, we have estrogen is all over our body, right? That's the one thing that we realize as we're studying and looking in depth into this. We have estrogen receptors in our brain, in our tissues, everywhere so it's not just limited to the uterus. That's another fallacy that these, hormones are only in the uterus and the ovaries. That's been the talk all the time. But it's all over our body, and that's why it impacts our joints, it impacts our brain, it impacts all the things. But let's break down menopause hormone therapy. The main indications for menopause hormone therapy are for what we call vasomotor symptoms or the hot flashes, sleep disturbance, and osteopenia, which Mimi was talking about, right? The precursor to osteoporosis. Those are the main indications, along with a long host of other indications that it can help with. But those are the main three: sleep disturbance, vasomotor, and osteopenia, along with mood changes. Again, mood shifts that are really out of the ordinary. It can be helpful for joint pain. It can be helpful for quote unquote brain fog, which is really something when you look back, you're like, my goodness, I was trying to find words. I couldn't find the words. I was missing the exit that I normally am able to. So these are the things that it can help with. So estrogen is the main hormone. It prevents, we talked about preventing bone loss, but estrogen is the main hormone. And if that is given in this combination of menopause hormone therapy. If a person still has their uterus in place, we can't just give exogenous or from the outside estrogen by itself. We have to balance it out with progesterone as well. That's why you see that they come in hand in hand. The progesterone is to protect the uterus and the endometrial lining, and to not put you at risk for endometrial cancer. They go hand in hand. Several options in terms of preparations for estrogen or estradiol. There are transdermal, so on the skin, a patch, gel, spray versions. Those versions tend to be the least risky because they bypass our liver and they bypass our internal metabolism, thereby being lower risk for heart attacks, stroke, and or blood clots. There's also the pill versions that you can take as well. The progesterone is supplied mostly as a micronized progesterone pill version. One can also use a progesterone IUD or other progesterone preparations that are also available. So, and then for localized symptoms, right? Because there's that vaginal dryness and vaginal skin thinning that can happen. One can also use specifically vaginal estrogen cream or an insert in the vaginal area. Since that is localized, one does not also need to use progesterone. It's not a systemic treatment, but it is incredibly helpful for women as they are in this menopause phase and they notice these changes. It can be quite uncomfortable, and it is a night and day relief for a lot of people. So let's talk a little bit about bioidentical hormones. I'm sure you've heard that term. It's basically hormones that are structurally identical to what we have naturally in our body, what we naturally produce. The current versions that are available of estradiol and micronized progesterone are actually FDA approved bioidentical hormones, quote unquote, right? The in the past, the hormones that were used in previous hormone therapy, like Premarin, progesterone, those were more synthetic progesterones, and that's why we try to avoid those these days for less risk. And Mimi will talk a little bit more about that.
Yeah, I think the bioidentical, discussion comes up often. And I usually, try to simplify it for people where they bypass the liver, essentially, where like micronized progesterone, it gets absorbed directly from your gut and doesn't need to be synthesized through the liver. And that's also one of the reasons why we prefer the topical estrogens. They don't have to go through the liver. But yeah, we should really talk about, the risks. Like that's the elephant in the room. Not just for our community, but for all women. I think there was a big scare in the early 2000s. And what happened was that there was a study that came out in 2002. But now that study has been reevaluated, and we know that most healthy women under the age of 60, if they start hormone therapy within 10 years of menopause, that the benefits actually outweigh the risk. Um, and that it's most effective for treating hot flashes and prevent fractures, supports heart health, if started early enough, and possibly even reduce the risk of Alzheimer's. Um, but just like any medication, there are some risks, and it's not for everybody. And that's the part that um, I think can be misleading on social media. So I really encourage people to talk to their primary care doctor, their gynecologist, and there's a lot of online access to, clinics that will have a very low threshold for prescribing hormones to you or other, treatments. But to just always, just check in with your primary care doctor, check in with your gynecologist, and make sure that you are a right candidate for these treatments. Um, Specifically, women who have a history of breast or endometrial cancer, any unexplained vaginal bleeding. Um, Even if you're like, oh, this is perimenopause, I know it is, all my friends have it at this time too. You should probably get that checked out. Um, and Jerusalem, you might have this experience as well, practicing women's health, is that I have done hundreds of endometrial biopsies. I have diagnosed very few endometrial cancers from those endometrial biopsies, but the risk of missing even one is so great because it is something so preventable, right? So any woman over 40, 45 whose BMI has been greater than 30 most of their life, I'm going to do a biopsy on, even though I know it's probably perimenopause, but that one chance that we miss this is too great a chance, too great a risk. Um, and then any woman over 50 with any unexplained or unusual bleeding should consider a biopsy first as well. Um, any woman with active liver disease should not be on hormone therapy. Any woman who's had prior blood clots, and actually prior unprovoked blood clots, right? So you didn't have like surgery and lay there for 3 weeks and then have a clot, but this is like you're just doing your normal life and now your leg is hurting and they find a clot in there. Those women should not be on hormone therapy. Any woman who's had a stroke or a heart attack should also avoid hormone therapy. So again, it's not for everybody, but if you are healthy and you feel like the symptoms are affecting your quality of life, then you might be a candidate for hormone therapy and to talk with your doctor about that. But if you're not, or if this is not a treatment option that you want, because one of the things that Kiko touched on is this has to be a shared decision making. The first provider she spoke of just gave her the prescription and told her to take it. It's kind of in the dark about why, what would it do for me? How will it harm me? How will it hurt me? Um, but if you're not a candidate, there are some alternatives, and Jerusalem can talk a little bit about that. And she can also talk a little bit about complementary and alternative treatments that are not medication.
Yeah, thank you, Mimi. I think really that emphasis on, going through the steps, making sure you talk to your provider. Absolutely. I have seen people that I've put on menopause hormone therapy that are just thanking me for listening, thanking me for finally, they've been suffering all this time with these symptoms and their quality of life has improved with those menopause hormone
Mhm.
treatments. And on the other side, we really have to pay attention. And that's why the context is important, making sure that you are up to date on your regular labs, like your cholesterol check, your blood pressure. If you're a smoker, cut back on smoking. All of these things affect your heart health. And then if we add on estrogen, then that puts you at higher risk. So all of those other things also have to be in place. Get your mammograms regularly, right? And making sure that you're on top of that. And I always tell folks, if I have any question, if I have any doubt, I'll send them to their oncologist to get clearance. I'll send them to a hematologist to get clearance to get on these medications if they need to be, right? But there's some people, for example, one that again, the risk is too high to go that route. And there's some people that actually don't want hormonal therapy. So we have to also respect their decision and help them find other ways to help the symptoms. So one of the way, I mean, if we're talking about medication, there are SSRIs. I mean, there are some SSRIs that are used normally for depression and anxiety at low doses or different doses that can help not only for the symptoms of the mood swings, but also for the hot flashes. Gabapentin is one medication that can do that. It's normally a medication for neuropathic pain or anti-seizure medication, but again, at low doses, it can help for some of the hot flashes, for some of those shifts that can happen. Veoza is another medication. I've used it a lot for my patients that have history of breast cancer and they cannot use hormones, but they have debilitating hot flashes that really keep them up all night. And at the end of the day, we want them to have quality of life, to be able to sleep, for their cells to recover, for them to continue to heal from this breast cancer. So really treating those vasomotor symptoms is essential, right? And those vasomotor symptoms for some people aggravate their heart health. So we really have to look at all of that in play. So those are some medication examples. And then there are other complementary alternative treatments. I am not an integrative medicine provider, but I really try to stay as much informed and listen to my patients, right? If they're going to their naturopathic doctor, if they're going to an acupuncturist, if they're going to their dietitian who's helping them, I also encourage and really help them to incorporate that into their lives as well. There's not a lot of great studies. What we need is, again, more and more studies on all the treatments, including the newer menopause hormone treatments, but also these complementary treatments. But I've had patients for whom acupuncture has been great, yoga, meditation, again, to bring down those cortisol levels. There's black cohosh, evening primrose oil, using soy products to boost your estrogen levels naturally. Those have helped for some folks, and yams as well, right? That's another that we hear about. Again, not many studies, but for some people, they can be helpful. And then back to lifestyle, I think that Mimi and I have talked about it quite a bit. I had a recent dietitian come and do a talk where she really, in this emphasis on protein is very real, right? So we tend not to get a lot of protein in our diets. We really need to boost that up and also build muscle mass. As we build muscle mass, that really helps with all the things, including breast cancer, etc., right? But it can really help for some of the symptoms and getting into a place where we're able to, as perimenopause comes, as menopause approaches, that we're able to kind of make it through in a healthy way. I do want to mention back to kind of some of the triggers that we want to avoid, right? So I'm sure you all have felt that glass of wine that has just magnified your hot flashes. You're like, why is my bed completely soaking wet? Oh, yeah, that glass of wine. I used to be able to have a glass of wine in my 20s and 30s, but now it's wreaking havoc. So alcohol is one thing, again, good to kind of think about reducing as we age. Um, Caffeine is another big trigger. So just thinking about all those other things as well. Um, thank you.
Yes, thank you, Jerusalem. I mean, I think that the information that you've shared and Kiko's story, I think has been very informative. I would, want to say like, if there was one takeaway that you would say from this whole discussion, like what would that be? What would you want everyone on this call to leave with?
I mean, I think you've said it as well, and Kiko specifically that one, that this transition can be normal, but it's the support that matters and making sure that you have somebody that's in front of you that where you feel heard, where you feel like you're in a safe space to discuss these issues that can be very uncomfortable, and then get comfortable talking about it because at the end of the day, you want to feel better, right? With the right information and care, women can navigate these stages feeling strong, feeling informed, and really in control of your health and your overall health, which is because this affects all aspects of our health.
Yep.
Yeah.
Yes. I would love to hear any questions from the audience. I would love to um, hear about any stories that people might want to share. Any questions, please drop them in the chat.
Feel free. This is an opportunity for you guys to
Yeah.
to check in.
I have a question. I think it's going to be too long for me to put it in the chat and wanted to ask. So one of the things that I have learned in my journey is that the hot flashes, mainly the hot flashes, I think, is really a symptom of the body, the liver not detoxing the estrogen that's in the blood flow appropriately. And I'm curious that just been questioning that how the medical field has not connected those two. Like we talk about, or even the moods, like we talk about like there's prescription or drugs out there that can help suppress the symptoms, but nobody was really talking about supporting the liver to detox the estrogen. Do you see anything or that coming very prevalent in the future?
I haven't, but I mean, I know when you were talking about that ex estrogen dominant, it's really that like we have naturally our body kind of shoots up that level of estrogen. So basically, we're trying to either bring it down or level it out. I haven't personally heard about that estrogen kind of collecting or sitting in the liver and having a hard time
Mhm.
flushing out. Again, it's very cyclical, so I know I have not heard about that component
Okay.
personally. No.
Yeah, I don't, the thing I've learned after so many years of practice is you don't know what you don't know, right? So I learn all the time from my patients. It's not something that we generally look at. I mean, we talked a little bit about bioidenticals and, choosing things that don't actually impact the liver if it's not necessary. And I do that, both with kidneys and liver for other medications as well. So I do, though, hear this, and maybe in a context that is not like a Western medicine perspective, right? Or if like internal medicine clinic or something like that, where I would hear it from people who are like functional medicine or integrative medicine. And so there may be something to it. I don't know that I'm the expert to answer that question for you. But I think as we age, it is good practice to avoid things that are unnecessary for our kidneys particularly, and also our liver to have to process, and our liver particularly as we are also probably trying to manage our cholesterol levels. And so that's where I see sometimes hormones and liver having um, a connection in where it's impacting our health. So things like your cholesterol being high, taking cholesterol medicine, taking oral hormone medications, and testosterone particularly, I think also does impact the liver and the cholesterol.
Yeah. The liver is the big filter of our body, right? The big filter. So most anything in toxins, it really filters all toxins through the liver. The context that I know about when I think about estrogen and the liver is the context around combined hormonal pills. So birth control pills that folks take can affect the liver, right? So we ask about, that's one of the questions we ask about before we put anybody on estrogen containing birth control pill. We ask, is there any liver disease, active liver disease that could make it worse? So that is one context. I did see a question from Elsa that I want to address. So once you're in your 40s, is everybody in the phase of perimenopause? Yes, yes, right. So this is that transition phase. We label it perimenopause or the transition phase, but it doesn't necessarily mean everybody has those symptoms. I always like when a person comes in for their wellness visit around 38, 39, I try to tell them, okay, in this next decade, these may be some things that you're going to start to see, and I want you to be aware of them. And if you see any of those things and they start really bothering you, do come in. For sure, we know that the cycle starts to shift, but not everybody's does it like that. But yes, cycles are going to start to shift. And
Um,
again, that might be 45 for somebody, that might be 42 for another person, that might be 48 for another person. And it really depends what else is going on, what all the other things, like if you have thyroid, etc. But yes, you are in perimenopause, and that's what it's called. And you may start to have some of these symptoms.
so, excuse me, there's a couple more questions. One thing that comes to mind for me, at least, is how little it's talked about in women's health from the start of menstruation to menopause, beyond even the doctor's room. How can mothers or parent figures support in learning about this as a way to address stigma and shame, but also promote better health outcomes? I love this question because I feel like maybe culturally, maybe it was just my family, but culturally is not something we talked about. Like I didn't want to talk about my period to my mother. I didn't know, it was very confusing. And even more, I ask some of my elders now about their menopause experience and they won't talk about it. And I think that this is a really good question because I used to do a teen clinic And I've had parents from similar cultural backgrounds to ours, and some Habesha parents as well, who are a little bit surprised that their daughters are having their periods at 10 years old, sometimes even 9, 11. It seems really early, but again, just like the age of menopause can move and change depending on lifestyle and diet. And so can the age of menarche, which is, puberty and starting your period. And so I think just talking about it, staying informed, sharing with our daughters, our sisters, um, and talking to our mothers as much as they're willing to talk to us, and then being open as other women approach us. Doesn't have to be a clinical discussion because we're not sick. This is not an illness. This is just, a process of which we move through, and how amazing and dynamic a woman's body is. So, yes, I do love that question. And I think personally, my way to move away from the stigma or the shame is to talk about it, to have forums like this and to discuss it because it's important to us and our well-being and how we function and maintain our role as women in our families, in our workplaces, and wherever it is. Because when you're burnt out, fatigued, haven't gotten enough sleep, or really, really bleeding, or having some other discomforts, you can't perform like you need to. And sometimes that's okay. You just need to know when you need a break, and society needs to understand that as well, because we're not sick. There was one
Yeah. So
other,
the question around brain fog, you want to?
yeah, you can address that one. There's
Well, I
another
just wanted to
one.
say that that's very real, right? The whole brain fog thing is really real, and quote unquote, and what is brain fog and how is it really defined? It's some of that, word finding, that short-term memory loss, the just feeling not necessarily completely confused, but we know we have to kind of tease that out because a lot of other things can happen around this time and other illnesses one can think about, right? There's attention deficit issues. Sometimes it's the lack of sleep and the hot flashes that create some of that brain fog, quote unquote. So testing that can, I mean, if you're really concerned about your memory, there can be like you can do a test with your primary care provider, which is a mini mental, it's called the mini mental. I can't think of the top of
Status
my head, but
exam.
it's, pardon me.
The mini mental status exam?
Yeah, the mini mental status exam. And basically, it's a quick test that your doctor can do just to check your memory. Um, and then not really any other testing outside of really, if you're thinking it's lack of focus, lack of concentration, maybe going towards attention deficit, your provider can also do a quick screen around that piece to tease that out. But also hormones, like even blood tests around thyroid, checking your anemia. Those can also, and then vitamin B12, lack of vitamins can, low vitamin B12 can present sometimes with memory and brain fog. So, really doing a thorough blood test and evaluation as well can be useful.
Yeah. And vitamin D.
Vitamin D is mega.
Vitamin D
Yes.
for your bones and for your
Number
mood
one, number
and for
one.
your
All of us should
hair.
be supplementing
People who
vitamin
have
D. We
anemia.
came from the continent, right? Our
Yes.
ancestors came from the continent where we had plenty of sunlight and melanin the production. But, we all need to supplement at least 2,000 to 4,000 international units, vitamin D3. All of us should be supplementing. It helps for sleep, it helps for our bone health, it helps for our heart health so many ways. And I
Mood.
mean, I was just telling my husband this morning, he was leaving, please take your, but I have it out on my counter nonstop. And if I get my little morning sun, like we get out and have our chai or bunna with our 10 a.m. sun, we really need that as well. I can't see all the questions. I didn't see the questions you had
She's
seen
putting it in the
in
document.
a
I have one here
different
that you
room. Yeah, go
like.
ahead.
It says, makes me wonder if this relates to lifestyle medicine. Are there ways to help our body adjust to these changes in addition to medication? Yes, of course. Exercise is a big one. Again, vitamin D. And if you don't want to take it in a supplement, even though if you live in a place where it's overcast all the time, like maybe Seattle or something, you might need some supplementation, but early morning sun between 9 and 10 a.m. for about 15 minutes without a whole lot of clothes covering everything. I mean, we can't be in our front yard naked, but we do get vitamin D from sunlight. Um, the closer you are to the equator, the more sunlight you can absorb and more vitamin D you can absorb. So, depending on where you live, that recommendation may change. But yeah, diet, avoiding the triggers like alcohol, caffeine. But I know for me, I can share a personal thing, white wine. I can drink red wine. I can't drink white wine. If I drink white wine, I will have a lot of night sweats. So, finding what is your trigger for you and avoiding that, meditation, prayer, acupuncture. I can tell you that more than half of the women I have sent to acupuncture specifically for menopausal symptoms and perimenopausal symptoms have had
Relief.
significant relief that they're able to report back to me. So if you've never tried acupuncture before, I mean, I love it. It works for many things, but it does particularly help with these symptoms. Um, well, there's a bunch more questions.
I
Yours,
have one I would like to answer because it's
yes,
really
yes.
important one. It says the question is what kind of labs to ask do you ask your doctor in your early 30s that can you can be aware of your symptoms. So labs come up all the time. I'm telling you, every other patient is like, okay, please check my hormones, check my hormonal panel. Totally understand, and we have to take it in the context, right? You saw those graphs that we put, especially in perimenopause. What stands out in those graphs, for especially for perimenopause, is that our hormones are all over the place and they can change from day to day. And as of yet, we don't have a good way to measure it accurately to give us good information to work on. So if you're in the midst of it, between 40 and 45, 40 and 50, where you're going through perimenopause, the labs don't give us good information, right? So it would be, we can check FSH, we can check LH, we can check your progesterone, we can check your estradiol, but it's only truly useful if we are concerned that something is happening early, like you're having premature menopause or the primary ovarian insufficiency, like I talked about. If you're starting to have these symptoms before 40 or you've stopped your period altogether, I would check an FSH at that point. If that number is over 25, and I would confirm it again, then I would say that you are in early menopause and we absolutely must treat you. Otherwise, you will be in trouble in terms of your bone health and many other things. So that's in that particular situation. Sometimes when it gets a little bit murky as you're getting towards menopause, I might check if have been on a hormone for a while or if we don't know for sure. But usually we diagnose it based on your symptoms, right? Just based on your symptoms is how we diagnose and how we help you. General labs and if you're like early 30s that you can be aware, like general labs, thyroid, I think, is always an important one. As a person that's assigned female at birth, really important to get your thyroid checked. Um, it's important to get your cholesterol checked, do a diabetes screening with what's called a A1C. Those are probably the top labs I would say that are really important. If you're a person like Mimi was talking earlier that has heavy periods, really heavy periods, and you're losing a lot of blood every month, and you have fatigue, a complete blood count to check your anemia, levels of your iron is very important as well. So those I would say that are the most important labs in your 30s, and depending on your family history, other labs might come into play as well.
Yeah, and I think when it comes to labs, I use this explanation for my patients often when it comes to hormones because what your estrogen was at 12 p.m. may not be what your estrogen is at 6 p.m. So if you consider your lab work as a still photograph of you standing on the beach with the waves in the background, that's that moment in time. But if you're taking a video and you're running on the beach, then you see the whole video. That would be more of what we would need to really say, oh, this is what's going on. So I order labs for hormones with the exception of thyroid. Other, like our FSH, LH, um, and estrogen and progesterone, I order them in the context of your symptoms. So one of the things we didn't touch on in this talk, and I want to get back to the questions, but we didn't talk about hair and hair loss. That is the thing that triggers a lot of lab work for me. So people who are anemic, so when you're losing a lot of blood, your iron, your body's keeping it to the places that is most necessary, so it's not going to your hair follicles. Vitamin D is a big one. Thyroid is a big one. Testosterone is a big one. And then the precursors to testosterone, I might order some of those. Is it DHEA labs? So the lab work is ordered based on the triggers. So I think in your 30s, I think why would you want the blood work? So if you're saying because I'm anticipating menopause, menopause is coming. You are human, you will age, you will get to menopause, or menopause will get to you. So you don't need a lab test to tell you that you're going to go into menopause. You will go into menopause. However, if the questions are more around like, can I conceive? Or am I still at risk of conceiving? I don't want to get pregnant anymore. Should I be on birth control?
Mhm.
So likely in your 30s, I probably didn't need labs to tell you that if you don't want a baby, you should probably do something about that. But if you can conceive, you want to make sure your AMH level, which is your anti-Müllerian hormone, and then they can also do certain ultrasounds to look at your ovarian reserve. So those are other labs that we could order, but always triggered for me, besides the baseline labs that we would always want to know, is based on your symptoms. Like, what are you experiencing? What are you feeling? And then we'll kind of sort of chase that then. So,
I want
and
to answer one question, maybe sorry to
yeah.
interrupt. Did about the breast cancer? I feel like we really should address that. It says I hear
Mhm.
some women worry about hormone therapy and risk of breast cancer, ovarian, uterine cancer. What would your advice be? One, we now have really good tools to check breast cancer risk, which is wonderful. So there are a couple tools where you can go online and see and put in some information to get your risk. One is called the Triacusic, and then there's one by the NIH. And now most places that do their mammograms with your mammogram, they'll have that listed and they'll give you your risk as well. So risk comes from primary relative, right? So a female primary relative with breast cancer in the past. If there's somebody like that, make sure you're starting your mammograms 10 years prior to their diagnosis and getting them annually. Those folks that have dense breast tissue can be also a little bit higher risk. When you're younger, you have dense breast tissue, but also in general, some people can have breast dense tissue all the way into their 50s. So that makes it harder for a mammogram to see clearly. But essentially, as long as your risk is low and your mammograms are normal, it's quite safe actually to take menopause hormone therapy. Really, it is quite safe. If there is a doubt and if you're at higher risk, the next step would be to do genetic testing and get genetic counseling and testing for genetics. There's a bracket that to get you can get testing through and your insurance will cover it. Um, and that information then will help us too, especially if your symptoms are so severe where alternative treatments or other medications are not helping and you want to try menopause hormone therapy. The nutrition piece, I think we've talked a little bit about really avoiding processed food, the food that we eat in this country. I mean, you know, right? The processed foods are real. The dyes, all the things that go into those foods can also, like Kiko said, they have to be filtered through the liver. And if you are predominantly eating processed foods or ultra processed foods, then you're really clogging up your liver. So really staying with just mostly organic and natural foods to the best of your ability. I know sometimes it's not possible, but whole grains, whole foods, the variety of colorful fruits or vegetables every day and vary it up and get your proteins in. Proteins are very important.
Yeah. There's a question here that I'd like to answer. It says, in our community, we often hear that there's a deadline to have a baby. From a
Mm.
medical perspective, is there actually a point where trying to conceive is no longer recommended? And how should we think about fertility as we start to experience symptoms of perimenopause or menopause? I love this question because I started out talking about this where, we have this misconception now that we can get pregnant whenever. Um, and then, our family back home or even right here is "Hindi machino matwalju," is always that pressure. But yes, well, there is no recommendation when to stop because even sex itself does help you with your hormones, releases oxytocin, brightens your skin, elevates your mood. So don't stop trying. However, there may come a time when it won't be possible anymore to conceive naturally. The good thing is that, now there are a lot of options. There's a lot has happened in the realm of fertility, where people are banking their eggs. And this is a conversation I am having more and more frequently as the years go on with women. I think when you think about egg freezing, there's the idea, like the ideal biological window for your eggs to make a baby would be like between 25 and 30, right? But 25 to 30 now, like we are doing some amazing things. We're building careers, we're finishing our education, we're traveling the world, we're doing many other things. It's not really our, traditional kind of idea of, go get married young and have children. And so that I don't know if freezing your eggs then either makes sense because then you have to pay for this, right? You have to pay for the rent of having your eggs frozen. So the ideal sweet spot is probably between 30 and 34, right? 32 being pretty like I try to at least have that conversation with people by 32. After that, and this is not a chronological thing. This is not an age thing exactly. This is based on your ovarian reserve. And so I mentioned the hormone, the anti-Mullerian hormone, the AMH, and then having an ultrasound, a specialized ultrasound that um, can figure out what your ovarian reserve is. So it's not just how many eggs you have, it's the quality of the eggs you have. So those two things together will determine how you would be able to, how well you might be able to conceive naturally. And so freezing your eggs while you still have both the quality and the quantity of eggs would be the ideal time. There's also the option to have your eggs fertilized and to freeze the embryos. You can do that as well with your partner. So there are ways, although they're not maybe as natural as we would hope them to be, there are ways to delay and defer pregnancy till a later time. And then, my grandparents did this. You can always have a surrogate, it's like, oh, legend sa tahat, right? I have aunties who were raised by other people because there were family and somebody needed a child, right? So you could have that more traditional option as well. And then, there's also the option for adoption and so there are things to think about, but I think that timeline that our grandparents, were moving on, that is the biological timeline, right? They knew, or maybe not for medical reasons, but they understood that there was a timeline biologically for us. And so, yeah, having the baby younger was more ideal. But now, creating a balance with what is realistic for us in this day and age and having the technology that we have now to make that possible. So, that is a good question. And I do always tell women, because I get 30-year-olds that come in and say, yeah, I'm thinking about having my first baby maybe in the next, 5 to 8 years. Like, okay, how would you want to achieve that? Let's talk about that. So, that's a great question. And then let's see if we have.
I was going to say something really quickly just to remind folks that, a lot of us are also waiting longer to have children. So, there is such a thing as you kind of, some of us that are having our kids like myself, and at 42, for example, where you're running into perimenopause during that postpartum time, right? Here you are in postpartum, your estrogen has tanked completely, so you're in postnatal depletion, and then you're running right up against perimenopause. So it can be a challenging time because the hormones are all over the place again because you've just had that baby. So there's pros and cons to all of it. I would, that no regrets at this point, but just saying that they're all different ways now that we've are doing this.
I am seeing that a lot more. It's like postpartum, lactation, perimenopause, and people have a run of like 3 to 4 years of I haven't been myself in half a decade. So yeah. But I also had my children a little bit later in life. Um, and appreciate the time that I had before kids to do all the things that I want to do. So I don't think it's a bad idea to defer your pregnancy, but just to be aware and to plan ahead. So let's see. I know that we are
I
way
think we're
over
good on
time.
questions,
Yeah, these are
unless
really
people
good
want to
questions.
unmute to
Yeah, you
ask.
can jump in and just ask your question. Let's see if we got any recommendations for vitamin D supplements. And somebody put in a link there. My favorite vitamin D supplement is sunshine, but we might need a little extra. I always need a little extra, and I'm always outside. I try to be
Yeah,
outside all the time,
those
and
of us that are in
that's
California are
tired.
grateful for that. The Bay
Yeah.
Area, yes. Not
Can,
today, but yes,
can
most
I
days.
just make an announcement, ladies? If in Tigrinya go video. ትግርኛ ዝዛረብ ሰብ ተሎ ድሕር ብትግርኛ ክገልፀልኩም ኮይና ሚዩት ስፒከር ኣብ ኣፅቂጥኩም ክትዛረቡ ትኽእሉ ኢኹም። I know we're over a little bit, so I apologize. Appreciate your time.
Yeah. I think, did we get to all the questions? Does anybody having just unmute and ask? No,
I
it's a
want to
great time.
highlight Betel's response about breast MRI. That's really important in the context of the breast cancer question. If you are at higher risk, in that the scoring that I was talking about, you can also get a breast MRI. Sometimes now the guidelines are alternating a breast MRI with a mammogram, and as long as folks are doing that, that can be a good way to take care of some of the issues as you're in higher risk, those folks with dense breast tissue as well.
Yeah, and they have I can't remember off the top of my head, but it's like a grading score that they'll give you. And when you meet the threshold to be an individual that would need an alternative
Yeah, the
MRI and mammogram.
Triarthusic, it's a Triarthusic
Yes,
score.
I can
That's
never
the
remember.
questionnaire that you put in,
Yep.
and we've
Mhm.
been using that now as well.
Yep.
Again, yeah.
Yes, Kisu, just unmute.
Hi.
Hi,
Yes, thank
welcome.
you. Thank you all for these for just all this information. My question that I had put in the chat and I put asking for a friend was how any do you have any tips or advice in terms of how to prepare? Because at least for me, I know with health things, I go into action when there's crisis. So I could be pre-diabetic for 15 years and not do anything, right? So I'm just curious when it comes, and again, right, it's not a disease, it's a process of life, but how any advice that you wish you had in terms of being just preparing.
Yeah, you know what? I can actually flip your question from not just a patient perspective, but a provider perspective. I can remember my very first menopause visit. I was like, 28. I felt so proud of my white coat, and I walked in the room, and there wasn't anything wrong with the lady. There really wasn't anything wrong with her. She's going through a natural process. She felt there was something wrong with her. And the conversation didn't start well, and it pretty much ended with, can you just get somebody with more gray hair? And it was life-changing because it really changed how I practiced, because there's nothing wrong, right? So how your provider addresses your need is not necessarily by saying, oh, you have this problem. But what Jerusalem said in the beginning is just listening, understanding what the patient's perspective is on what is happening, you know, or what they're feeling. So it doesn't necessarily mean that I have to come up with a diagnosis or have to necessarily say, aha, this is what's wrong. But listening to the person and then saying, okay, I understand that this does not feel normal for you. These are the things that I know I can explain for you, and anything outside of this, we can, try to explore further. So then maybe some labs and things like that. But I'm so grateful for that very uncomfortable encounter very early on in my career because it really changed the way that I understood how my role was to be, and that not everything a patient will come in with is something that is a problem necessarily medically, but could be a problem for them, right? And if I don't address it in a way that they understood, then I didn't actually address anything, and it was a lost opportunity and, just basically a blighted encounter, right? Nothing came of it except the person feeling unheard. And this, I think, is what happens a lot. Um, I feel like there's a disparity in women's health. I mean, we clearly see it in childbirth, and other, situations, but something I don't want to call menopause benign, right? Because the experience is real, but something that is not really going to make you sick, right? But somebody actually maybe took the day off work, set an appointment, paid a copay because they felt something enough to want to discuss it with someone they consider to be an expert. And then you get brushed off as, oh, there's nothing wrong with you, just exercise some more, eat better, which is, I think, part of Kiko's story is like she felt like there was something going on. She went in there, she expressed herself, and they gave her a prescription and minimized what was going on and didn't really offer anything to her. With or without the prescription, she could have left with more information to help her situation and may have not needed the prescription at the time. She may have needed the prescription. It's really unclear because that there wasn't a full loop around what she came in for and how her questions were answered. So I don't know if that's helpful to you, Kisu, but I think that finding a provider that you trust and being able to have a shared decision-making process when you're coming up with a treatment plan or even coming up with what actually is the problem that we're identifying.
Can I add to that also? Because I felt very alone, and when the symptoms came up, none of my friends my age were experienced frozen shoulder. None of them were experiencing insomnia the way I was, and it did impact my cognitive ability. And going to work every day, I was like, how do people who are physicians or corporate America, how are they functioning? How have these women in menopause, perimenopause have functioned? Because I couldn't function and I felt very alone. And I wished I had asked more questions of my mother. And not that the only thing looking back that I was like, oh, I don't remember her hot flashes, but I do remember her mood swings. And it didn't occur to me, right, that these were related. So I think trying to seek friendship and others, if you are with people who are older than you, start asking them about what's happening, and younger folks too, right? And then I like just even knowing that, oh, I thought I was early going to be diagnosed with Alzheimer. Like I was like, I'm too young for this, and we don't have a history of it. So, but that's what it felt like. Like I couldn't and I have impeccable memory. Like I don't need to write a list. All of a sudden, like I can't remember. I felt very alone. So
It's debilitating, yeah.
it is, and it is. And I'm like, I don't understand women my age, how they're working and functioning every day. And
And it affects your mental health,
it
when
does.
you feel that way.
Yeah, and I'm in tech, so I'm with all these men, and they're not understanding what's happening. You can't really say, "Hey, I'm going through menopause," but sometimes I do in one-on-one, like leave me alone. Like I can't remember, and they'll be like, "Why don't you remember this? We went over it yesterday," and I'm like, "Hey, I just don't." Being
They're
honest,
actually looking at menopause in the workplace now and making it a
thank
thing,
God,
like, yeah,
thank God.
to make sure that it's addressed
Yeah.
and honored. Yeah.
But the one thing that I would have done differently, I would have prioritized my health a lot quicker. Like I think get your body in shape. That even working out regularly and prioritizing that will help you so much. And I think, as Habesha people, our diet is pretty good. The fasting and all of that helps. But The two things I would have done was definitely worked out and made that a priority. I'm a healthy eater, so that wasn't a thing, but talking to women around me a little bit more, a lot quicker, and just being curious about what that process is.
Thank you so much, Kiko. That's fantastic. And 100% agree with you about the exercise component. And I really attribute that to why I did not go through an intense perimenopause time. It's because I'd been working out the whole time. I really do believe that. And 100% getting other people and making a community of folks. This is a start right here. Those of us that are just having this conversation openly and talking about it. And as Mimi was saying before, there's so much now, there's just so much information and misinformation out there, teasing out what the information you can use and what's real, right? So that is critical. But really, paying attention to your health. Go get some of those basic labs. Start eating well, avoiding those high processed, ultra processed foods, looking at the food pyramid differently, like more plant-based. We love our siga and our tips, etc., but really limiting that. We need to limit that. We need to be in the quote fasting home food. Most of the time is delicious. Who doesn't like churro, right? Who doesn't like churro? And kebab is fine. It is clarified butter, right? So just making sure that and that colorful, like adding the beets and the red peppers and all of that, really, really important. And bumping up our protein. But
Protein.
yeah,
I am a proponent
I
of
know.
protein.
Protein and fiber.
Yeah.
Fiber.
Oh
If
yeah,
you
I'm
really
telling
increase
you
your
that
fiber.
psyllium husk, the or what we have that.
But
What's the
telva. How about our
telva? There
telva?
you go,
That's what
telva.
we love.
I
It's
know
so
our
good
mothers
for
used to
you.
have telva. Maybe that's
Yeah.
why they were fine, right?
Good
Anyway,
for your
I
breast
digress.
health, good for your cholesterol, good for your metabolism. It's telva is amazing. There's a lot of things. There was a really interesting question or
Can I
comment.
just add one more before I let you guys? I
Sorry.
also having insurance is great, and sometimes they won't pay for the things that you need, particularly if you don't have the symptoms. Like if you're 30 and you have questions and you want to get your labs just to have a benchmark. I wish I went forward and had benchmarks. I was like, oh, I'm not there yet. Go do it. Pay out of pocket if you have to. There's a lot of hormone testing now that are available. Your vitamin D, any of that. Spend the money on yourself and your house. It's worth it. Don't be limited by what your insurance covers.
Let's see, there was a question from Tizita. It's a pretty long one. Okay. Okay, we'll wait for that question at the end. I got a message because it's actually a very important one and I think is why we're here. Um, okay. Yes, Talba. Is that our last question? I think. You see any other questions in here? Jerusalem?
No, I think I responded to the
Yeah,
one.
I think this will be our last question then. So, really important. How has the historical legacy of unethical clinical experimentation and systemic inequities in the healthcare industry shaped fear and mistrust among Black and other communities of color toward medical diagnosis and support, including this specific related matter? And how might a Habesha professional working within this sector critically interpret and respond to these concerns? Um, I love that question, Tizita. We were at an event together at the Eritrean church a few weeks ago, and this is something that, was, and Jerusalem was there too, and you actually were seeing the patient. So a lot of these people had primary care providers, but want to hear it from somebody that looks like them because that implies that you won't harm me. I trust you. I don't know. I walk in a grocery store and I see an Abisha person. I want to get in that line, right? It's the same idea. You feel kinship. And I think that that's why representation in healthcare is so important. I get this a lot. And I think that that there is a lot of fear that we're going to be over medicated, we're going to be overdiagnosed, we're going to be overtreated. And then on the flip side, there is just as much fear as they're not going to believe me. They're going to gaslight me and tell me that everything is fine. They're not going to diagnose me appropriately. And so it is it's very tricky. I think language too, whether you speak the language or not, sometimes language is just culture, right? You might not speak the exact words, but how you would speak to a person, right? Or what you might say to them, how, the language really works, right? Are you very direct, like English is? You have this diagnosis and this is your prognosis, and or that can scare people. And one of the um, interpreters at a hospital that I used to work at had taught me that it's not the words that I'm using. It's how would that person take that information? Because I would be really frustrated speaking Amharic, but maybe not good enough to really have a whole visit in Amharic with a patient. I have the interpreter there, and he's saying something not quite what I was saying. And I'm feeling frustrated, but really, I was just young and felt like I knew everything because what he taught me was that I can tell them something now to bring them back to tell them something more later. Like if the way you were presenting it is like a gursha that is so big that the person can't swallow it. You know what I mean? And so it's culture is so many things, It's like just seeing a person and they see you and they feel like, oh, this person looks like me. I can trust them. And then speaking to you, all of a sudden you are saying the same things that every other provider they've seen that didn't look like you. And not just that you're saying the same thing, but you're saying it in the same way. Now they're like, whoa, okay, maybe not her. Maybe she doesn't understand me either. And so it's it's a very fine line. It's being able to read your audience, read the room, understand who you're speaking with and what their experience is in this healthcare journey, that when they present to your room, you can't use that cookie cutter approach. I can't use the same conversation in the same way with somebody who was born and raised here, who's Habesha, as I would maybe with somebody who just came a year or so ago from back home, a little bit older maybe, or maybe lived in the village in the countryside and not lived in Addis. Like it's a different conversation every time, and you have to be able to ask the person what they're comfortable with, like, and let them tell you, let them guide you how they want you to treat them in that way, and still have a plan of how you'll deliver all that information. Is that helpful to Zita? Does that answer your question? And yours?
Yeah, thank
Yeah,
you. Thank you, Mimi. Thank you for sure.
thanks. Jerusalem, what about you? Like, how do you deal with that?
Oh my goodness, on so many different levels. I've been very, very lucky that the very first place that I practiced and started my journey as a nurse practitioner was a community health center in Oakland, where I would say about 40% of my patients were Habesha patients. So, and it was the most rewarding experience I've had. 10 years I worked there, and oh my goodness. So it was just beautiful. And it's been hard to step away from that, but now I'm trying to get back into that as I'm at the end of my career. Like, okay, like going to volunteer, getting back to our community, and honestly, we don't even have to go back to Ethiopia, Eritrea, or go to do that. We have huge populations here that are
Mhm.
looking for our support. I just pinged in there the Black Girls Guide to Navigating Menopause, which is another group that they do great work around, again, culturally specific for folks that are Black. So take a look at that link for those of you. As a healthcare provider, I'm mentoring new providers daily and trying to get more of us in this role. So if any of you are interested in becoming a nurse practitioner or a PA, etc., please feel free to contact us, contact me. Um, and I mean, we need to be in this place. 100%. And it's great to see everybody's faces. Yeah.
Yes.
I can put my email in there.
And for those of you in the Bay Area, primarily in the East Bay, One Love Center for Health has a new Habesha Initiative program, and we have actually two programs. One is a house calls program, so you can contact us at onelovehealth.org, and I can put that in the chat. And then the other one that we're hoping to launch a cohort, maybe this summer, but probably in fall. It's a Tenai Stilling program. These are for it's a group or shared visits with folks that have cardio, renal, or metabolic diseases. So things like diabetes, high blood pressure, heart disease, kidney disease. And we'll have a cohort of 6 to 8 people in each group. We're hoping to have a group in Amharic, a group in Tigrinya, and a group in English. And so if you're interested in that, we are primarily looking for Medicare folks. However, if you don't have insurance, that's okay. Just contact us anyway. We also do accept Medi-Cal and some private insurances. And so, if you're interested in that, what it'll be is a monthly visit for a series of 6 months where we'd address one topic each month, and we will have a meal together that we will prepare maybe in its entirety or maybe just partially prepare together. We might not be making the lit for the injera, but we might make injera, or at least make some of the what to go with it. And we'll have a nutritionist. We will have a sort of mental health or somatic health sort of piece where we'll have a bunna ceremony and talk about the things that stress us or things that impact our health or our community. And then we'll have the clinical piece where each person in the group will have their labs. And depending on your diagnosis, if it's diabetes or whatever, we're monitoring the appropriate lab work and then evaluating again at the end, in the middle, and again at the end of the 6 months to see, if there was any change in that lab work. And also, incorporating mental health and movement and exercise into all of that. So I think we are communal people. We eat together on a tray. I think we can benefit from having a communal healthcare experience. So that's our Tanastilling program that should be coming out. So contact us at One Love. Let me put it in the chat. I can't
And I wanted
chew
to say that
and
I'm a provider at One Medical. I've been there for 13 years now, and I see patients specifically for menopause and perimenopause. You can book a visit specifically for menopause and perimenopause. My panel is full, but I'll still see you for that. And if you are interested in being on my panel, please email me on my personal email and I'll put you on the panel. I've been there for so long, I have close to 900 patients, but I would, I'm absolutely happy to see anybody if there's a need, and we do take insurance.
yes. Any closing remarks from anybody? So Almaz did put something in the chat. She said she'd love to hear from everybody. If you could leave 2 key takeaways or a piece of advice to carry with them. Yeah, so again, seek help, build community with other women, talk to your elders. Our elders are our teachers, um, and and then pass that on to our daughters, our nieces, our children. Like let them know early so they can understand that these things are normal.
Yeah, and I would say absolutely, if you feel off, you know your body. You know yourself better than anybody else. Absolutely listen to your gut, listen to your inner voice that is telling that something is off. And like Kiko did, don't give up. Continue to ask for help. reach out, and you need to be heard, and you're not alone. We are here. You're not alone. I don't want anybody to ever feel alone in this journey. And we're here for you. There is a lot of, and I hear from a lot of my patients, there is a lot of medical trauma out there where people feel traumatized and unheard in their
Yes.
medical visits. And my job day to day is to make sure that nobody ever feels that you feel safe when you come to see me, that is a safe space I create. Because, we are vulnerable. When you're not feeling well, you're very vulnerable. And Mimi and I both feel that it should always be a safe place, and always feel free to ask your questions. Thank you
Yes.
all for being here, by the way. I love it.
Thank you. And
Thank you,
we,
Kiko.
One thing that I would love to leave you all with, as difficult as the perimenopause and menopause journey is, it's a beautiful thing. It is it's an initiation into your golden years. You will,
wonderful.
like we as women, provide so much support and nourishment to others and this is like the transitioning into your nourishment into yourself. So as difficult as it might be in the beginning, it's a beautiful thing, and I do look forward to that, and I can already see the benefits of how I'm changing and evolving, and look forward to it.
Yes, we do have a feedback form, and that might be in the chat, I believe. If you could please fill that out. Thank you all for joining this community discussion. And remember to subscribe to the YouTube page for Habesha Health, and you can see other content from previous discussions. I just really appreciate being in community with all of you today. Thank you so much.
Thank you.
Yes, and please donate to Habesha Health. We appreciate that as well.
Okay.